Hi, my name is Shelley Weiss, and I'm going to talk for the next 10 minutes about children who have neurodevelopmental problems and insomnia, and the use, or let's say the reason that people might use melatonin or think of other medications to help your child sleep better. So this is a Facebook Live series brought to you by Better Nights, Better Days for children with neurodevelopmental disabilities. We're going to be launching our research and looking for children who are school-aged with cerebral palsy, autism, fetal alcohol syndrome, and ADHD, who also have insomnia. And we are going to be recruiting children for our trial, which hopefully will start in about the next month. So this is a low-tech presentation, so I don't have PowerPoint, but I'm just going to show you some slides just to give you some information. So for people who are interested in learning more about Better Nights, Better Days, you can go to our website, www.ndd.betternightsbetterdays.ca. So probably if you're listening to this Facebook Live, you've heard some of our other talks more about children, why they have insomnia, different groups of children, and how children with autism, why they may have insomnia, or children with cerebral palsy. So I'm going to expect that people already know a little bit about insomnia and just talk about treatment and specifically about melatonin and medications. So I want to put it in perspective, just in case you haven't listened to our other Facebook Live talks. When you think about treatment of children with neurodevelopmental disabilities or children who are typically developing, we think of 5 steps. And it's important that we don't go to step 5 without thinking about step 1 to 4. Because most children who have insomnia, so they just either have trouble falling asleep, don't sleep through the night, or wake up too early in the morning. It's usually behavioral insomnia, and it's usually can be solved without step 5. So step 5 is only for a very few children where we cannot improve their sleep when we go from step 1 to 4. So I'm not going to concentrate on step 1 to 4 because you've already learned about that. I'll just say briefly that you need to, when your child is not sleeping well, you need to think about what other problems may be contributing to poor sleep, such as obstructive sleep apnea, seizures or epilepsy, reflux, like from gastrointestinal reflux, and you always have to treat those before you can expect children to sleep better. The next is education. So we need to have parents educated about what's expected at different ages for normal sleep and other issues just around sleep. The next is implementing healthy sleep practices, such as having children be in bed at a consistent time, waking up at a consistent time, having breakfast every morning, having a quiet bedtime routine, having no electronics in the bedroom. And you've heard about these issues before. The next, number 4, is specific behavior interventions, behavioral sleep interventions. And if you end up wanting to participate in our research through the internet, we've developed a e-health intervention, which really goes very specifically into these different interventions and helps you to help your child sleep better. And as I said before, medication is the last thing that we do. Sometimes in combination with 1 to 4, we may add medication, but we never skip 1 to 4 and go right to medication because we know that that doesn't work. So there's no medication that will help your child fall asleep, keep them asleep all night. They won't have any side effects, so they won't be tired during the day from the medicine. And it won't wear off, like it will last, I could give you a prescription and it would last for a year or 2 years. So there is no medication that works like that. Definitely some medicines will help for the short term, But when we think about children who have neurodevelopmental disorders, we always have to think about those steps 1 to 4, and then maybe adding melatonin or medication if your child is not sleeping well, despite you having looked at the first 4 steps. So I just want to show you another picture that it's the exact same information, but it just shows you that it's like a pyramid. Lots of families need the bottom of the pyramid. Some families need to improve sleep practices. Some families need to learn specific sleep interventions. And we're talking about a small number of families where they may use melatonin or medications. So before I talk about melatonin, we call melatonin the hormone of darkness, because what happens is there are many different cues that help us to sleep at night and be awake during the day. One of these is melatonin, because when it's dark at night, melatonin is released in your brain, and it's called the hormone of darkness because it helps you fall asleep. So before you can understand about melatonin, you need to understand about the circadian rhythm. So a circadian rhythm is the rhythm that we have in our bodies that helps us to be awake during the day and asleep at night. And you can see this blue is wake, or this is during the day, and the yellow is night or sleeping. And what happens is that we all, as humans, we live on a 24-and-a-half-hour cycle. If we didn't have jobs and had to go to school and be up in the morning. And every day we bring our cycle back to 24 hours by these different cues that help us to sleep at night at a consistent time and wake up in the morning. And one of the cues is melatonin. Just in case you don't know or you haven't looked, you can just find this on Google. I found this image on the internet. This is a picture of how melatonin works, the natural type that we all release each night to help us fall asleep. So what happens is, here's the sun and here's the eye. So when the sun, or when you have light, it stops the production. PG is the pineal gland where melatonin is made in the brain. So having sunlight stops the production of melatonin. When it's dark, so when we take away the sun, then the retina, the back of the eye, signals to the brain through very complex mechanisms to release melatonin, and you can see that's what helps us fall asleep at night. The very interesting thing about this sort of biologic clock or circadian clock in our brains, it's a virtual clock, is that there actually are many organs that also have a circadian mechanism or a biologic clock. So it's not just sleep and wake. You can see here, these are just pictures of the heart, the liver, the pancreas, the gut. So we have actually very intricate timing to our different body organs, but we're just going to talk about the brain and melatonin today. So melatonin comes in many forms. This is just, I'm not trying to promote this type. This is just a picture I got off the internet. And in Canada, you can go to your local drugstore and you can buy melatonin. You don't need a prescription. It wasn't always like that. Probably about 10 years ago, you needed a prescription. And in some countries, even today, you cannot just get melatonin. So melatonin comes in different forms. People make it as a liquid. Some people make it as like a wafer that the child has that melts. Some companies make it as a pill, and some companies make it as a pill that they call controlled release, with the idea that it would let the melatonin into your system sort of over many hours through the night. Let me tell you about the short-acting melatonin first. So definitely we know it's effective, that it will decrease the time it takes to fall asleep and will increase sleep time. So research tells us that. It doesn't decrease night wakings. And actually melatonin only lasts in your body about 2 or 3 hours. So it's called a short half-life. That's what we call it in the biology of pharmacotherapy. So it doesn't keep you asleep, but it definitely shortens the time to fall asleep, so your overall sleep time will be increased. There's a lot of controversy over what dose to give, and some people will prescribe, or now you can buy it over the counter. Some people will say an older child may take 10 milligrams and a small child may take 1 milligram. We don't actually know the doses. Probably if you take 10 milligrams, you're actually excreting most of it. You're not really needing a 10 milligram dose. We definitely, as sleep experts, myself and my colleagues, we do not advocate giving melatonin to healthy, typically developing children who have insomnia, because those children should be able to learn to sleep through the night using the first four mechanisms I told you, which are making sure there's no problem like sleep apnea, teaching parents about sleep, improving sleep practices, and then using behavioral interventions. But we do know that children with neurodevelopmental disorders, even after parents have tried to improve their sleep, in addition to the sleep intervention, so trying to improve sleep through behavioral methods, we know that melatonin can also be effective for helping children at least fall asleep. This has been studied in children with autism, children with ADHD, and other neurologic problems. One of the things we worry about melatonin is that in your body, it's a natural hormone. But when you give melatonin, like you buy it in the drugstore, you're giving what's called a supraphysiologic dose. So much more than your natural, than your brain would release at night. We don't know if in 10 years you give a child this supraphysiologic dose, it's going to have a side effect on their puberty or any other problem. We don't suspect that it's going to have a problem, but because we don't know, we are more cautious in children who are typically developing because we know we can treat their problems without melatonin. Children with neurodevelopmental disorders, we know that it's actually so important for them to sleep that these potential side effects are a bit less worrisome, because the interventions that we use in typically developing children may not work as well, and so they may actually benefit from melatonin. I'll just talk about the short-acting versus the long-acting type. So because melatonin is a natural substance, there isn't actually a pharmacy that makes it. It's made, it's a naturopathic substance. And so there isn't a pharmacy company who has kind of spent a lot of money to make sure that an enteric-coated melatonin releases slowly in the body in the same way that if you put a child on an enteric-coated anti-epileptic drug or enteric-coated ASA, we know that that has been tested to release slowly. So people are very interested in doing more research in terms of the benefits of slow-release melatonin. But right now, if you buy it in the drugstore and it's called slow release, you're not really sure if it's fast-acting or regular release or slow release. So let me just see if I have any other pictures that I want to show you before I see if anybody has any questions. So I guess I just want to talk a little bit about other medications. So there are many medications. I'll show you. This is actually from some research that was done in 2011, so a few years ago. But these are some of the other types of medicines that have been studied in children with developmental disabilities who have trouble sleeping with insomnia, either falling asleep, staying asleep, or waking up too early in the morning. So people have looked at antihistamines. We talked about melatonin, alpha adrenergic agonists such as clonidine, benzodiazepines such as Valium or Ativan, pyrimidine derivatives. These are the non-benzodiazepine drugs like zopiclone and zaleplon. Antidepressants, cyclic antidepressants like nortriptyline or amitriptyline, atypical antipsychotics like risperidol, and then conventional antipsychotics. So definitely there are some children who benefit from these very specialized medications which have potential for more side effects, haven't been studied as much in pediatrics, but there is some benefit if you are working very closely with your pediatrician or psychologist to try and improve your child's sleep, and you try melatonin and it doesn't work. As long as, I'm going to end with my first slide because I think it's really the most important. I think the most important message is you cannot, which I think I now have told you enough times, you can't just skip to number 5, adding medication and expecting that this is going to solve your child's sleep problem. Whether your child is typically developing or has a neurodevelopmental disorder, you have to think of the treatment of their sleep problem as addressing step 1, 2, 3, and 4 very carefully before you think about adding medication. So I'm going to, again, just finish with this picture. I hope you didn't mind my low-tech talk. But if you are interested in finding out more about our research program, which is a e-health intervention for children with neurodevelopmental disabilities who are school age with autism, FASD, cerebral palsy, or ADHD, myself and Dr. Penny Corkum at Dalhousie University are the co-PIs for this study. Sydney Dale McGrath is our amazing research manager, and we are taking names on our website if you're interested. When the study opens, we will be emailing people to see who actually is interested and is eligible, and there's information on the website about eligibility for the study. I'll just show you the website again. And I hope that this information is helpful. And if you don't participate in the research, or you're not eligible or not interested, I hope I've taught you something about melatonin and sleep medications today. And thanks for your attention. I'll just see if there's any questions. I'm going to look at the side. So we have posted our website. And I'll just wait a few minutes and see if there are any questions or comments. I don't know where you are today if you're listening, but we're expecting a big snowstorm tomorrow. So I hope everybody stays safe and warm. Maybe doesn't have to go outside tomorrow. So I have a question. I'll just say Sarah, not your last name. If melatonin has a short half-life, can it be used to help with early waking? So that's a really good question. It probably does not help with early waking. I know from talking to many families that some people try, if their child wakes up at 1 or 2 in the morning, to give them melatonin, hoping that that would help with an early waking. But that's not a very physiologic way to use melatonin, because it really should be given an hour before bedtime to help sleep onset, because in our brains, it's the hormone of darkness and it's produced at night, not at 1 in the morning. So unfortunately, it probably isn't going to help with children who have early morning wakings. However, what will help are those other steps, looking at specific behavioral interventions about how your child might fall asleep at night. And actually, by improving how your child falls asleep at night, I don't know, Sarah, if this is for you specifically, but just in general, that might help with early morning wakings. Thanks for the question. It looks like I'm just going to click on comments here. So it looks like there might be some comments. Okay, I'll just wait one more minute. I know people are busy, and if you're in the Eastern time zone, you're getting ready for lunch. Okay, well, anyways, I hope you learned about melatonin and medication, a little bit more about sleep in children with neurodevelopmental disorders, and thanks for your attention. Bye.